Hello everyone, my name is Ameline Saouli and I'm a fifth-year medical student. So I want to start with a short story. A few days ago, one of my relatives had just given birth and suddenly she became very unwell. And I was the one taking care of her, and as I was rushing her to the hospital, my mind kept racing. Could this be bleeding? Could this be an infection? Or could this be a clot? So that experience made me realize how critical it is to recognize postpartum emergency quickly and how imaging can guide us to the right diagnosis. So today I'll be talking about imaging in postpartum emergencies, a practical approach. Here's the roadmap for today's talk. We'll begin with the imaging toolbox in postpartum care, then move to the most urgent complication, postpartum hemorrhage, and after that we'll cover infection and vascular complication, and finally some other postpartum emergencies. Why are we even talking about this? Because postpartum emergencies are a leading cause of maternal mortality worldwide. According to the WHO, more than 70,000 women die each year from postpartum hemorrhage, and many of these deaths occur within the first 24 hours. And yet, with the right recognition and timely imaging, many of these lives can be saved. So for us, medical student and future clinician, knowing what to look for and which imaging to use can literally save lives. When a new mom is sick, the first imaging we reach for is usually ultrasound. It's safe, quick, and at bedside. It's also excellent for spotting hemorrhage, retained tissue, or fluid collections. But ultrasound has limits: bowel, gas, stool, or deep pelvic structures that may not be visible. That's where CT comes in. So CT is valuable in unstable or complex cases where we need to see the hidden bleeding, the hematomas, or vascular injuries. And finally, the MRI shines when we need detail. For example, we want to distinguish retained product from clot, evaluating scar defects, or looking at deep pelvic infections. Before we get into emergencies, let's quickly review normal pelvic anatomy on ultrasound. So let's orient ourselves. Anteriorly, we see the abdominal wall, then here is the urinary bladder, and just posterior to that lies the uterus. So here is the endometrium. It's a central bright stripe. Then it's surrounded by the myometrium, which looks uniform, and then just between those two is the junctional zone. Then if we look at this image here, we can see the ovary, and often you'll see small black circle inside, and those are the follicles. So in terms of technique, transvaginal ultrasound gives us the best resolution for the uterus, ovaries, and tube, but transabdominal ultrasound can also be useful, but its quality is often reduced because of bowel gas and stool that will block the sound wave. And a practical tip: always try to start locating the bladder because the uterus will be posterior to it. Now let's look at the CT. So this gives us a cross-sectional view of the pelvis. You can see anteriorly your rectus abdominis muscle, and then posteriorly your sacrum. Here is your right ovary, your left ovary, and here is your uterus. So you can see it's in the midline. So being comfortable with CT pelvic anatomy is key, because when there's a hematoma or vascular injury, you'll know exactly where to look. And finally, MRI. Here is your uterus. You can see it's beautifully outlined. You can distinguish your endometrium, your myometrium, and then in between your junctional zone. So you can see anteriorly your bladder and then posteriorly the rectum. So this soft tissue detail is why MRI is so powerful in detecting deep infections, scar defect, or distinguishing clot from retained product. Now, let's start with the most urgent complication, postpartum hemorrhage. So as we already said, it's the leading cause of maternal mortality worldwide. Postpartum hemorrhage simply means heavy bleeding after delivery. If it happens in the first 24 hours, we call it primary, but if it happens later and up to 12 weeks postpartum, we call it secondary. We also classify bleeding by severity. It can be minor if it's from 500 to 1000 ml of blood loss, and then major if it's more than 1000 milliliter. And this can quickly become life-threatening if not managed promptly. The causes are easy to remember, which are your 4 T's. So your tone, tissue, trauma, thrombine. For tone, the uterus isn't contracting, and this is the most common cause. Then we have tissue, which can be retained placenta or membrane left inside. On ultrasound, these usually appear as a mass, sometimes with blood flow. Then for trauma, it can be laceration of the cervix, vagina, or a large hematoma. And then for clotting, it's just for thrombin, it's just your clotting disorder where bleeding is more generalized. Now let's look at uterine atony, which is the most common cause of postpartum hemorrhage. So this is a case from a 33-year-old woman after a vaginal delivery. So contrast-enhanced CT image obtained during the arterial phase, shown in this picture, and then the delay phase in this picture. So you can see at the level of the uterine body, the diffuse contrast extravasation inside the uterine cavity. So that's ongoing bleeding, most likely from a small artery or vein. And notice how the shape of the uterus has changed, and that is due to partial contraction. So clinically, atony is when the uterus fails to contract after delivery, so bleeding continues from the placental bed. Imaging isn't always required, it's usually a clinical diagnosis, but when done, CT can demonstrate active bleeding and it can help confirm the source. Now let's look at trauma-related postpartum hemorrhage, laceration, and hematomas. So on the contrast-enhanced CT, you can see a large hematoma in the broad ligament, which is marked with the asterisk, and notice how it displays the uterus and its surrounding structure. So that's a key clue that bleeding is tracking into the ligament rather than staying confined in the cavity. Then if you look at the large arrows, you can see contrast extravasations, and these patients often need urgent intervention. You'll also see that the uterus itself is pushed slightly off midline because of the hematoma bulk. And this is exactly where CT helps us, because ultrasound might only show a vague pelvic mass, but CT can clearly define the extent of the hematoma, the involvement of the broad ligament, and whether there is active bleeding or not. Now let's take a closer look at one of the trickier causes of postpartum hemorrhage, RPOC, which means retained product of conception. So here is the uterus in a sagittal view, and you can see here the endometrium, which looks thickened. And before I explain further, take a moment and try to spot where the abnormality might be. So it's actually quite subtle, and you can see a small echogenic area here that could represent a mass. And this is exactly the challenge of a 2D grayscale. So RPOC can be very difficult to see. Sometimes all we notice is a widened endometrial stripe or a vague echogenic mass in the canal. But remember, this could just be a hematoma which has no vascularity, and this is why Doppler assessment is essential. So now let's switch over to Doppler, and here it is. And I'll show you the key finding that confirm RPOC. So when we switch to color Doppler, there are two key red flags that point toward RPOC. So first is increased vascularity. So it's often in the fundus, which is the most common site. And then the second thing is high velocity flow. So on spectral Doppler, you'll see peak systolic velocity above 100 centimeters per second. And these vascular findings are what really help us distinguishing from RPOC from something like a clot, which has no internal flow. And I'll show you an example of that high flow, high velocity Doppler signal in the next slide. Here is a real case. So a 30-year-old woman, 4 weeks after a C-section, presents with bleeding. So on grayscale, there was just a subtle echogenic mass in the cavity, but when we switch on Doppler, you will see an increase in vascularity, and also you'll see the high velocity flow. And I'll show you now the video. So here is your increased vascularity, and then here you can see your high velocity flow. So you can see it was above 160 centimeters per second. So to summarize, the two red flags for RPOC are increased vascularity and high velocity Doppler signals. And in terms of management, these cases often require dilation and curettage, so DNC. Now we'll talk about infection and vascular problems. Endometritis is simply inflammation of the endometrium. It usually happens postpartum or after a procedure. So a big red flag is a history like manual removal of the placenta, because that's a major risk factor for infection. Clinically, your patient will present with pain, fever, abdominal bleeding, and a tender uterus. So this is why an endovaginal exam is essential. You need to directly assess for uterine tenderness and ask your patient, does this hurt? Because tenderness is a key diagnostic pointer. So on ultrasound, the main finding that you would see is the thickened endometrium, and sometimes you can see fluid inside. If fluid is blood or pus, it will often look heterogeneous, but you may also see echogenic foci of air, which is a strong clue for infection. So here you can see them here. And the big teaching pearl here is if you see high vascularity, think of RPOC. But then if there's no vascularity and a tender uterus, it's more likely endometritis. And management here is antibiotic, not surgery. So here is another patient. So she presented with abdominal pain and vaginal discharge for 3 weeks after C-section. So this is a contrast enhanced CT and the portal venous phase. So take a look at the uterus here. Where's my pointer? So here you can see intracavitary collection of heterogeneous density, and you can see the internal gas bubble. You can see it both here, and that's a strong clue for infection. So CT is not always first line for endometritis, but it becomes very useful when the presentation is prolonged or if ultrasound is inconclusive. So it allows us to see the full extent of the disease, the presence of gas, and to exclude other pelvic or abdominal complication. So remember I said she had a C-section. Here you can see her C-section scar. Now let's look at another rare but serious complication, ovarian vein thrombosis. So it typically presents with right lower quadrant pain, fever for about 10 days postpartum, and often it does not respond to antibiotic. So ultrasound is difficult here because of relying bowel gas, so CT and MRI are the modality of choice. So on this CT, you can see, here is your ovarian vein, you can see a feeling defect in your right ovarian vein. And this is important because untreated ovarian vein thrombosis can extend and become PE, can cause PE. Here is the MRI equivalent. So on this coronal and axial view, you can see your ovarian vein, which has the thrombosis. This is your IVC, and this is your aorta, and this is your kidneys. So you can also see the relation to the IVC, kidneys, and other pelvic structure. So again, the key message is that ovarian vein thrombosis is rare, but you must think of it if a postpartum patient has pain and fever that is not explained by an infection. And again, CT or MRI will give you the answer. Now we've gone through the big three: hemorrhage, infection, and thrombosis, but there are a few others emergency we can't forget in the postpartum setting. So let's go through two important ones: pelvic abscess and pulmonary embolism. Here is a pelvic abscess. So it's located between your uterus and your rectum. So you can see here is a well-defined collection with heterogeneous density, and sometimes you'll notice enhancing wall, and if there's gas inside, that's a very strong indicator of infection. So clinically, your patient will present with fever, pelvic pain, and persistent discharge. And why is imaging important? Because abscesses can mimic hematomas or complex fluid collections. So CT helps us define the exact location, the size, and whether there's extension into the adjacent spaces, which is critical because you want to know if your patient needs antibiotic, drainage, or surgery. And finally, don't forget your pulmonary embolism. So a blood clot in the lungs are actually one of the leading causes of maternal death after delivery. So the postpartum period, you know, that is a hypercoagulable state, so women are at an increased risk. So on CTPA, what we look for is for a feeling defect inside your pulmonary arteries, as you can see it here. So if you suspect it clinically, so if, for example, a postpartum woman, she presents with sudden shortness of breath, chest pain, or hypoxia, the test of choice is CTPA. And remember, always apply your Wells criteria to guide pretest probability. Thank you for watching. I begin this talk with the story of my relative and the uncertainty I felt in that moment. So what I hope you take away is that imaging gives us clarity in those critical situations because it helps us recognize life-threatening postpartum emergency quickly and act when it matters most. So imaging doesn't just guide diagnosis, it saves lives.